So first up, we have resume water vapor therapy. Is it safe to continue antiplatelet or anticoagulation medicine by Dr. Samuel Lee again? So, Samuel?
Good afternoon, esteemed judges, colleagues, and friends. I'm Samuel. I would like to share our results that shows that resumed water vapor therapy is safe in a patient who is continuing on antiplatelet anticoagulation medications. Lower urinary tract symptoms, or LUTS, with benign prostatic hyperplasia, or BPH, is a common disease which affects 50 to 70% of men above 50 years of age. Current treatment options are pharmacotherapy with alpha blockers and 5-alpha reductase inhibitors, or surgical treatment. Many men are not keen to continue on pharmacotherapy long term, either due to the side effects or poor response to treatment. This results in poor compliance. Hence, some men look for surgical alternatives. Transurethral resection of prostate, or TURP, is the standard of care. However, it is associated with the risk of bleeding, urinary incontinence, and ejaculatory disorders, among other complications, which has been well described. Patients who are at high risk of thromboembolic events are on antiplatelet anticoagulation therapy will either not be suitable for surgical treatment or have to accept the increased risk of thromboembolic events when they suspend their antiplatelet anticoagulation medications perioperatively. If they are not a surgical candidate and are in urinary retention, they are condemned to be on a long-term catheter lifelong. With improvements in healthcare, many patients are living longer with cardiac and thromboembolic diseases. Patients seeking treatment for BPH tend to be older and have multiple comorbidities. Many men are on an antiplatelet medication for their cardiovascular health as well. We would like to share that resumed water vapor therapy is a good alternative to men with BPH, with the lower bleeding risk and milder side effects. During the resumed pivotal study, antiplatelet and anticoagulation medication had a 10-day pre- and post-procedure washout period. The company has recommended to suspend antiplatelet anticoagulation medication in the perioperative period. There are some studies that have described performing resume while on antiplatelet anticoagulation therapy. However, these are multi-center and retrospective studies, and the authors were not able to identify and confirm which patients have suspended or continued their antiplatelet anticoagulation medications. Hence, this study aims to collect prospective data to evaluate the outcomes of performing resume while continuing antiplatelet anticoagulation therapy. The primary objective was to evaluate the safety and efficacy of resume for all patients that underwent the procedure between November 2021 to March 2022 in Sengkang General Hospital, Singapore. This was performed by a single surgeon. A subgroup of these patients were on antiplatelet anticoagulation therapy, and they were continued on these medications perioperatively. Baseline characteristics were collected prior to the procedure, such as a complete history and a physical examination. Prostate volume and intravesical prostatic protrusion were obtained on point-of-care ultrasonography. Patients with a prostate volume of between 30 to 80 mils were then offered resume therapy. We have excluded patients with prostate volumes of more than 80 mils on bedside ultrasound, or they have active UTI that has not been treated, or they have an elevated PSA that has not been previously assessed. PSA testing was obtained prior to the procedure. Uroflowmetry was performed and maximum urinary flow rate, or the Qmax, was recorded. They were followed up prospectively for 3 months. The patients were called weekly in the first month to check on their complications. All procedures were performed with the resume system and performed under monitored anesthesia care. Number of steam injections were dependent on prostate size and prostate morphology. So there were 9 men who undergone Rezum while on antiplatelet anticoagulation therapy during this study period. Mean age of 74 years and mean prostate volume of 45 mils, as shown. There were 7 patients on a single antiplatelet therapy, 1 patient on a novel anticoagulation therapy, and 1 patient was on both dual antiplatelet therapy and on apixaban. There was an improvement in Qmax points from 7.9 mils at baseline to 16.2 mils at the 3-month mark. 8 out of 9 patients had a successful expected removal of catheter. No patients complained of severe hematuria or passing out clots on discharge. We do not report any Clavin-Dindo grade classification of more than 1 at 30 days. There was 1 patient who had a bladder neck contracture, which required elective transurethral bladder neck incision after the 2-month mark. So from this study of 9 patients, we found that there were no readmissions for bleeding complications post-operatively. This is to be expected because unlike traditional TURP, there was no disruption of the urothelium, therefore risk of bleeding is lower. Objectively, the patients enjoyed improvements in Qmax at the 3-month mark, while still staying on antiplatelet anticoagulation therapy for thromboembolic protection during the perioperative period. These patients may have otherwise been kept on suboptimal medical therapy or kept on a long-term catheter for bladder outlet obstruction. Limitations to our study include having a small sample size. Severe post-procedure bleeding is uncommon, and we may only be reassured if we are able to evaluate a larger sample size. So avenues for future research would include achieving a larger sample size. Thank you for your attention.
Okay, do we have any questions from our judges?
So, I assume they are Rezum done on other patients that are controlled?
Yes, actually we have a total of 23 patients that underwent Rezum during the study period. So this presentation only focused on the 9 patients that are continued on antiplatelet anticoagulation medication. I actually presented another poster, moderated poster, earlier today. Yeah.
Okay, are there any other questions?
Well, what are the anticoagulations which the patients have in this group?
So we have 9 patients. I think 7 of them have single antiplatelet therapy, which is either aspirin or Plavix.
Okay.
1 of them were on dual antiplatelet therapy and on apixaban. The other one was on a NOAC.
Any experience with patient on warfarin?
We do not have any patients on warfarin. They're meant for this.
But will your institution perform Rezum in patients with warfarin?
So our inclusion criteria for our study was actually all patients. So any patients with antiplatelet or anticoagulation therapy were included. So yes, if they are on warfarin and if they choose to go for Rezum therapy, they will be included in our study.
Yep. One more question.
This 9 patients, is it single surgeon series or?
Yes, it's a single surgeon series. All performed with the same instrument. Yeah.
Sorry. Earlier on, I didn't catch whether or not this is Lawida here. You have IRB for collecting data on patients on anticoagulation.
Yes. So institutional review board approval was obtained in SKH to collect outcome measures for benign neurological conditions. So this includes the data collection.
Any issue with the IRB? Because I think the company actually recommends stopping antiplatelets and anticoagulation. So you all did not encounter any issues, or the IRB board was not aware of the recommendations?
no issues from IRB from what I experienced.
Okay, do we have any final questions? If not, thank you very much, Samuel. Thank you for a good presentation. And on that interesting note, we'll carry on. So our next presentation is single versus multiple renal arteries in kidney transplantation, a systematic review and a patient-level meta-analysis. And this is going to be presented by Ki Yong.
Good evening, everyone. My name is Ki Yong. I'm a Year 4 medical student from the National University of Singapore. Today I'll be presenting on the project Single versus Multiple Renal Arteries in Kidney Transplantation, a systematic review and meta-analysis. So as a background, there's a rising demand for kidney transplants as evidenced by an increasing number of patients on the wait list. Hence, there's an impetus to include as many patients as possible on the donor list. And one particular debate has been focused on that of multiple renal arteries, or MRAs, against single renal arteries, or SRAs. So for now, living donor transplants with multiple renal arteries present unique surgical challenges. And current evidence is equivocal on the effect of MRAs on recipient graft and overall survival. Hence, we aim to evaluate if single renal artery or multiple renal artery transplant affects graft survival and overall survival of the recipients. We did so by conducting first an electronic literature search on PubMed, EMBase, and Scopus, and we retrieved individual patient data from all studies. So this individual patient data, or IPD, was pooled in a meta-analysis for graft survival and overall survival. So briefly, how we did this is firstly, we used a graphical reconstructive algorithm for Kaplan-Meier curves. So as you can see here on the right of the screen, there's a Kaplan-Meier curve from one of our included studies. And to start off, we tabulate the data using a graphical reconstructive algorithm, and then we derive hazard ratios for single versus multiple renal arteries, and we pull them all together. Next, we also perform some sensitivity analysis using studies which use purely open and purely laparoscopic donor nephrectomy. And we also perform meta-regression of baseline characteristics versus the relative outcomes of single versus multiple renal arteries. In total, we retrieved 14 studies, of which 13 reported on graft survival with a total of 8,400 patients, as well as 9 studies which reported on overall survival with a total of 6,912 patients. So for graft survival, we found that there's actually no significant difference in hazard ratio between single and multiple renal arteries, even when restricted to open-only or laparoscopic-only surgeries. A two-stage analysis was also concordant. So for the one-stage analysis, I'd like to draw everyone's attention to the 0.94 hazard ratio, as well as the 95% confidence interval that crosses 1, showing that it's not significant. For the two-stage analysis, this is a conventional meta-analysis where the hazard ratios of individual studies are pooled together instead of their individual patient data. So here you can also see that the threshold crosses 1 and there is no significant association. In addition, we found on meta-regression that there are no significant associations. What this means clinically is that the donor age, recipient age, as well as percentage of double renal arteries among the multiple renal artery subgroup, as well as the percentage of open surgeries, it does not have any effect on the relative graft survival of multiple versus single renal arteries. In addition, for overall survival, we also noted that there is no significant hazard ratio difference between single and multiple renal arteries. Also, similarly to the graft survival, there's no difference when restricted to open or laparoscopic only. As you can see here, the 95% interval crosses 1, hazard ratio is 0.95. And our two-stage analysis is also concordant with the fact that there is no difference. In addition, there were also insufficient studies on meta-regression because 10 studies are needed as a minimum for meta-regression, but we only have 9 reporting this outcome. So multiple renal arteries are present in 20 to 30% of all individuals and pose a tedious surgical challenge. The lack of collateral circulation means that damage to one branch intraoperatively can result in graft loss. In addition, laparoscopic retrieval also requires careful surgical technique and dissection can be difficult. So this either requires an on-bench vascular reconstruction or multiple anastomosis, which will increase the warm ischemia time. So our study provides prognostication for this single versus multiple renal artery debate. It's the first of its kind to use individual patient data, which is regarded as the gold standard of meta-analysis, using a large cohort with robust analysis. and hence we provide level 2 evidence for similar graft and overall survival between multiple and single renal arteries. In addition, previous meta-analyses have shown conflicting results. For instance, one showed that there were similar 5-year overall survival and graft survival rates between single and multiple renal arteries, while another showed that there was a lower rate of 1-year graft survival for multiple renal arteries. The difference between these studies and ours is that they used only study-level data, whereas we used the more robust analysis using individual patient data. So in conclusion, we conclude that multiple renal arteries are not inferior nor contraindicated to single renal arteries for living donor transplantation. So equal consideration can be given to the two when looking for potential living donors. Thank you very much for your kind attention, and I'm happy to take any questions from the audience.
Oh, we happen to have a transplant surgeon on our judging panel.
Yeah, but it's all statistics and deep level statistics are very impressive. But may I ask, what tool did you use? I mean, what background you are biostatistician. I mean, what background are you? Sorry.
I'm a medical student.
Medical student.
Yeah.
Okay.
But then, what the statistical software that we use for this purpose was R. So R in RStudio. So it allows us to conduct the analysis right from the graphical all the way to the statistics level. Yeah.
But you had to gather all the literature and then compile it and then okay.
Yeah.
Thank you. Impressive.
Do we have any other questions from the judging panel? Any questions from the floor?
Audience? Yes, Kali.
I have two questions. Can you share with us the technical challenges during the hilar dissection for dual arteries? And number two, did you do separate end-to-side anastomosis, or did you reconstruct and then anastomose singly?
Yeah, so maybe I'll answer the second question first. So with regard to surgical technique, actually all these studies, they use different variations of surgical technique that most of them did not specify on. So as a meta-analysis, we aim to pull all this heterogeneous data on, and some of the studies do not specify what kind of surgeries they are doing. Yeah, so whether end-to-side or any other different techniques was not really expressed much in these individual component studies. But I think the main message of this meta-analysis is that whatever technique you use, open or laparoscopic or as an overall cohort, there is no difference in outcomes of these two different types of kidneys that have been donated. Yeah. And then in response to the first question, I actually kind of forgot what the first question was. It was about the dissection. Yeah, okay. So this one also, unfortunately, not really specified in the studies as well. Yeah. So from what I understand, most of these studies only report the clinical outcomes, but they do not elaborate much on what their technique is. Yeah.
Hi, can I ask a question? Hi.
Oh.
Congratulations on your meta-analysis. I understand the overall result was a non-significant difference. So meta-analysis are often influenced by the studies that go into it. Do we know how many were actually RCTs, how many were just cohort studies, how many were retrospective?
Yeah.
And the other thing is that if it's a very heterogeneous group of studies, that will also influence the final outcome.
Yes, I agree. So actually for randomized trials perspective, there are no randomized trials in this field. So I guess from a trials perspective, it is difficult to run a randomized trial because there might not be enough donors with multiple renal arteries to include. So actually all of the studies that we included were retrospective cohort studies. And in that we concede that there is a risk of bias that is unavoidable with this meta-analysis because it is not the highest level of evidence for randomized trials. So that is one limitation of our study. Yes.
Okay, thank you very much. Thanks, Ki-Yong. Okay, we'll move on to the next presentation. So the next presentation is entitled Direct Head-to-Head Comparison of the Diagnostic Accuracy of Prostate-Specific PSMA PET.
Good afternoon, ladies and gentlemen. The excellent diagnostic capabilities of PSMA is now well established in existing literature. However, the use of this next-generation imaging modality in a relatively large cohort of patients with primary prostate cancer can be a resource-intensive endeavor. The decision to incorporate PSMA into the primary staging pathway and potentially replace conventional imaging is one that thus needs to be backed up by definitive evidence on their relative diagnostic accuracies. So to this end, previous reviews have undertaken indirect comparisons that have evaluated the outcomes of separate studies, either on PSMA alone or conventional imaging alone. This is problematic because the presence of confounders can lead to an imbalanced evaluation. Firstly, the disease stage at which the separate imaging modalities are performed are very likely to differ since they're not in the same patients. And secondly, the presence of selection criteria is present. So, for example, in retrospective studies on PSMA alone, selection criteria is often either unspecified or in the context of inconclusive conventional imaging findings, whereas for studies on conventional imaging alone, no such selection criteria exists. As a result, empirical evidence have in fact shown that indirect comparisons yield significantly different evidence from direct comparisons in diagnostic test accuracy or DTA reviews. So following the emergence of new data, we now present the first direct head-to-head comparison of PSMA and conventional imaging for the primary tumor, nodal, and bone metastasis staging of prostate cancer. And we thus aim to answer the question definitively of whether and when PSMA should be used as first-line imaging for primary prostate cancer. We strictly included only studies where PSMA and conventional imaging were performed for the same patient cohort, where a reference standard was used, and where the time interval between imaging as well as between imaging and surgery was known. In order to perform pairwise comparisons, we used likelihood ratio tests comparing bivariate mixed effects meta-regression models with and without the covariate terms for sensitivity, specificity, as well as imaging type. We also use hierarchical summary receiver operating curves that best demonstrate the distributions of sensitivity and specificity, which are known to vary with each other. So firstly, for tumor staging, we asked the question of whether PSMA would outperform multiparametric MRI. And what we found was that it had significantly higher sensitivity than NP-MRI when it was performed using the PET-MRI tracer. However, there were no significant difference observed between PSMA PET-CT and NP-MRI. So what this result suggests to us is that the spatial resolution, which we know that NP-MRI provides, cannot be replaced, but can indeed be complemented by the avidity of smaller lesions accorded by PSMA, and thus PSMA PET-MRI does indeed have a role in primary tumor staging. Next, for nodal staging, we asked two questions. Firstly, does PSMA outperform CT-AP? Secondly, does it outperform NP-MRI? And what we found was that PSMA did indeed have a higher sensitivity as well as specificity than both conventional imaging modalities. Significantly, while previous reviews had found no or limited differences between the specificities of PSMA and NP-MRI, in our analysis, even when we restricted it to the 8 prospective studies that prospectively recruited patients to undergo both PSMA and NP-MRI, PSMA was found to be significantly more specific. Why is this an important finding? Because the potential for the overtreatment of false positive lesions due to the uptake of tracer by benign lesions remains a concern for PSMA. And what our results here show is that despite this limitation, PSMA still remains superior to conventional imaging and should be utilized given its discriminatory value for micronodal metastases easily missed on morphological imaging. So over here, our HS rocks show the distribution of data, the summary points, and over here the PET lines shown in green is a visual representation of the pairwise analysis undertaken. Next, in order to better select patients who will most benefit from the improved diagnostic accuracy of PSMA, we performed subgroup analysis by ISUP grade group according to the availability of data. And what we found was that the relative ratio of PSMA sensitivity to conventional imaging sensitivity was higher at lower grade groups. And what this suggests to us is that using PSMA over conventional imaging will provide a greater diagnostic benefit for patients with lower grade cancers. Lastly, for bone metastasis staging, we asked whether PSMA would outperform bone scan, and we found that it had a significantly higher sensitivity as well as specificity. So interestingly, in our direct comparison, where 5 of 6 included studies performed bone scan enhanced by SPECT-CT, we observed a larger difference in sensitivity and specificity than a previous indirect comparison where all studies on bone scan had performed bone scan alone. So what this suggests is this. that it affirms the fact that PSMA overcomes an intrinsic limitation of bone scan in identifying marrow-based or lytic skeletal metastases, and thus has a definitive role in primary bone metastasis staging. Moving on to the strengths of this SRMA. We believe that the multiple steps taken to ensure that a balanced evaluation was performed between PSMA and conventional imaging strengthens the reliability of the evidence that I've presented to you today. Firstly, we perform a direct head-to-head comparison, which is the gold standard methodology recommended by Cochrane DTA guidelines. Secondly, our analysis accounted for time interval, something that an indirect comparison has no ability to do. And we in fact found that it was a significant source of heterogeneity across many levels of our analysis. And what this means is that it underscores the importance of performing a comparison of two imaging modalities only when they are performed in the same patient cohort and preferably at the same time. Lastly, our review includes the largest number of prospective studies to date for which we can be sure that patients were not pre-selected to undergo PSMA. Additionally, we are also the first DTA review to compare PSMA to MPMRI for tumor staging, as well as PSMA to CTAP for nodal staging. However, due to the paucity of data, we were unable to evaluate the effect of PSMA and conventional imaging on management change, a hot topic currently. And secondly, we were unable to perform subgroup analysis by other risk stratifiers. And we thus recommend that future diagnostic comparative studies report these data and stratify them by clinical parameters so we can better select patients who will most benefit from PSMA. So in conclusion, in intermediate to high-risk patients, our direct comparison shows that PSMA outperforms MPMRI in terms of sensitivity for tumor staging, CTAP and MPMRI in nodal staging with larger differences at lower grade groups, as well as bone scan in bone staging. We believe that as we await long-term data on after PSMA to become available, our direct head-to-head comparison provides reliable evidence that suggests PSMA improves diagnostic accuracy in these settings and should be considered for first-line imaging of primary prostate cancer. Thank you.
Thank you very much. Do we have any questions from the judges?
Yeah, I think it's a nice study, and we all know that the sensitivity and specificity of conventional imaging and PSMA is related to many factors, one of which is PSA level. Is there a median PSA level in this study cohort? Because I assume that the PSA is very high, there will be not much of a difference whether you do a conventional imaging versus a PSMA scan, which is much more expensive. And my second question is there any analysis on the cost effectiveness of using this approach? Because PSMA scan is very, very expensive. Is it overkill, especially when there's no oncological outcome data to actually support this this line of management?
So thank you so much for your question. So regard to the first question about the effect of PSA. So actually our study had on the outset wanted to investigate whether or not patients with higher PSA would more benefit from would more benefit from PSMA over conventional imaging. However, because of the paucity of data, we were unable to do this. I cannot quite recite to you the exact median of the PSA value in our study now, but I would say that from a statistical point of view, this value is not very useful because in our study, we've only included patients with intermediate to high-risk prostate cancer for whom, we can be more or less sure that, we can say that their PSA levels are a bit higher. But what we can say from this study that, where patients are probably having higher PSA levels than the average prostate cancer cohort, is that in this intermediate to high risk group, PSMA definitely has an improved diagnostic ability over MPMRI. So it is true that at higher grade cancers, MPMRI becomes more sensitive and more specific. But what we have shown is that even in these cases, PSMA is still even more so sensitive and specific and should be used instead. And with regards to your second question about the cost effectiveness, unfortunately, we were unable to also undertake this analysis because of the paucity of data. However, what I believe our evidence here contributes to the conversation is that we have found a significant difference between PSMA as well as conventional imaging. So take, for example, the differences between PSMA and bone scan. We found a difference in sensitivity and specificity of about 25 and 27%. And that's a lot more than what has been previously reported. So even though this is a theoretical extension of the agreement, I don't think it's very far for us to say that, this would significantly improve or significantly result in a stage migration of patients with primary prostate cancer, which would shift their oncological outcomes and shift the cost-benefit analysis of whether or not you're going to perform definitive therapy. And there have been even studies as well as previous reviews published about whether this would PSMA used on top of normograms to predict the need for pelvic lymph node dissection. And of course, avoiding that would definitely reduce the cost necessary, especially for patients with primary prostate cancer, for whom undergoing definitive therapy without any oncological benefit would be of great cost to them. Yeah, so I hope that answered your questions. Thank you.
Okay, do we have any other further questions? If not, we're going to move on. Thank you very much for your presentation. Our next presentation is the functional outcomes and oncologic control after focal therapy for localized clinically significant prostate cancer, the outcomes of a phase 2 trial. So Yukwang, thank you.
Okay. Okay, a very good evening, everyone. We are pleased to present the results of our phase 2 study on prostate focal cryotherapy, of which we look at the functional outcomes and oncological control for focal therapy in localized clinically significant prostate cancer. This trial was funded by the National Medical Research Council and registered for clinical trial. It ran from 2018 to 21, of which we ran it and faced a lot of challenges running it during the COVID pandemic. But we are happy to conclude and share the results here today. So the concept of focal therapy is to treat the cancer focus rather than the entire prostate gland, thereby sparing the side effects of urinary incontinence or sexual dysfunction associated with surgery or radiation-induced toxicity, improvement in imaging, and now the routinely performed MRI ultrasound fusion biopsy techniques have allowed us to localize the prostate cancer with greater precision, thereby allowing a very targeted treatment approach. However, many earlier studies of focal therapy had mainly focused on low-risk prostate cancer as an adjunct to active surveillance. And even so, the functional benefits of urinary and sexual preservations were not comprehensively assessed. And to add granularity, there hasn't been much of an Asia series that evaluated focal therapy for prostate cancer. So with all this consideration in mind, we designed this phase 2 study trial with a primary focus to determine the change in major functional domains after focal cryotherapy using the validated EPIC questionnaire in patients with clinically significant prostate cancer. There were also a few other secondary outcomes that we measured. First, to assess the oncological control determined by the absence of clinically significant prostate cancer in field, which is within the ablated field, and outfield, which is outside the ablated field at 1 year mandatory rebiopsy. We also look at any treatment-related adverse events defined by the Cleveland-Lindo classification, and last but not least, other composite cancer outcomes such as failure-free and overall survival. So to determine the primary outcome, sample size calculation revealed that 24 patients would need to be recruited to detect a mean difference of 5 points in each of the EPIC subdomains using a PET-T test at an alpha or p-value of 0.0125. This is after Bonferroni correction and a power of 80%. So this is how the recruitment and trial were carried out. Firstly, the recruitment starts off with all patients undergoing a standardized 3 Tesla multiparametric MRI, followed by a transperineal targeted and saturation biopsy. The inclusion criteria were based on 2 previous Delphi consensus, and we include patients with PSA up to 20, biopsy Gleason score of up to 4+4, multiparametric MRI did not show any gross extracapsular extension, index lesion of not more than 3 mils, and less than 2 biopsy confirmed clinically significant prostate cancer lesions on MRI. So once recruited, all patients have a baseline functional assessment with the EPIC questionnaire, which has the domains of sexual, urinary, bowel, and hormonal function. Following which, focal cryotherapy is performed as a day procedure. This is a transperineal procedure of 2 freestall cycles, and our technique of cryotherapy has been previously presented and published. So after treatment, the patients are followed up at 1, 3, 6, and 12 months with regular PSA, EPIC questionnaire, and uroflowmetry. And at 12 months, all patients had a repeat MRI but followed by a mandatory biopsy, which is illustrated in this diagram. So it comprised of what we call the tracking biopsy, highlighted by the blue dots, which is biopsy of the ablation site, targeted biopsy of the new MRI lesions, which is highlighted by the yellow dots, and lastly, saturation biopsy of rest of the prostate gland, which is highlighted by the black dots. So here we share the results of our study. Altogether, 28 patients were recruited. This trial recruited predominantly intermediate risk prostate cancer, but we had 4 patients with Gleason 4+4. And a total of 42 lesions were ablated with a median MRI lesion size of 9 millimeters. So the role of a complementary saturation biopsy had also identified MRI invisible clinically significant prostate cancer in 7 patients. And we'd like to highlight this using the diagnostic map from one of the patients. So if you can see this patient, his diagnostic map showed MRI lesion the right posterior peripheral zone. It was Pirates 4, and it turns out to be Gleason 3+4 on the biopsy. But on the saturation biopsy, you can see that there are 2 other areas of a positive core in the right anterior peripheral zone. And one of them was even a 4+3, which kind of upstaged the patient. But more importantly, there's really a change in the ablation map. Because if the patient had only MRI targeted biopsy, he would have what we call a right posterior quadrant ablation. But with these new saturation findings of the anterior lesion, he had ultimately had a right hemigland ablation. So for the primary functional outcome, a transient worsening of urinary symptoms with a mean difference of 16 points and sexual function with a mean difference of 11 points were observed at 1 month, but had complete recovery back to baseline at 3 months. Subgroup analysis also showed that for patients who had ablation extending to the adjacent neurovascular bundle, as depicted by this illustration, there was a slightly delayed recovery of the sexual function at 6 months. But otherwise, the hormonal and bowel function were all preserved. When evaluating the oncological outcomes, 22 patients, which represent close to 80%, were free from any clinically significant prostate cancer. Of the 6 patients with recurrences, 2 had infill, 3 had outfill, and 1 had both infill and outfill recurrences. So 1 patient had a single core of Gleason 3+4, so he opted for active surveillance strategy. 4 patients had repeat focal cryotherapy, while the last patient with both infill and outfill recurrence ultimately had an uncomplicated radical prostatectomy. All cases were performed as day surgery with no complication or readmission. So to conclude, I think there are 3 important take-home messages from this phase 2 study. Firstly, cryotherapy is a safe procedure with a low complication rate. In our series, all were performed as day surgery with a mean operating time of 70 minutes. There were no readmission or complication. Secondly, the functional outcomes were preserved with only a transient deterioration of sexual and urinary functions at 1 month with complete recovery at 3 months. And last but not least, the oncological outcome is promising with 80% of clinically significant prostate cancer free rate at 1 year, and this is via a very comprehensive rebiopsy strategy, which probably can reliably represent any potential residual cancer burden. And with that, I've come to the end of my presentation, and thank you for your time.
Okay, do we have any questions from the judging panel?
Hi. I noted that you guys choose the Phoenix-Houston criteria for definition of recurrence after HIFU. Why do you guys choose that? Is there any evidence or?
Oh, that's a very good question. So I think what we are trying to show is that I think in the past when cryotherapy or when ablative modalities were first started, it was about whole gland. So people really look at the Phoenix criteria to determine a rebiopsy strategy. But what we find out there is that when you look at focal therapy, the PSA is actually not a very good estimation. So you have that slide where you show that if you use a Phoenix criteria, 7 patients kind of fulfilled the Phoenix criteria, but only 4 of them actually had clinically significant prostate cancer or rebiopsy. So it's just to highlight that you really, in a focal therapy setting, you shouldn't be using a Phoenix criteria as a way to select patients who will need a biopsy or not.
Question is, I understand that you all do a saturation biopsy. Okay, but this saturation biopsy is done, I assume, with the biobot, right?
Mm.
Yeah. So how sure are we that the initial saturation biopsy, or rather the second saturation biopsy, did not actually picked up cancer in the first saturation biopsy? Because the biobot doesn't allow the template for the first biopsy to be stored. Yeah. So every time you fuse the image and you ask the computer to auto saturate it, it may still have a bias, a sampling error in this. Yeah. So is this being accounted for?
So I think that's a limitation of how the fusion techniques or biopsy techniques in general is. I think what we are trying to achieve here is that we call it carpet bomb the whole prostate at a repeat biopsy, so that as much as possible this provides the most objective way of seeing whether there's any residual disease. And in actual fact, even in current setting, a lot of the focal therapy series don't do a routine repeat biopsy protocol. With regards to that question, that was important because we're actually working with BioBot on the next generation of fusion where you actually can plot your initial diagnostic biopsy onto the rebiopsy map in 1 year. So you know where you biopsy before, where there was maybe some 3+3 that you did ablate your active surveillance that, and rebiopsy that area to make sure that you really can comprehensively assess that part of the prostate.
Okay, thank you very much, Yikwang. So, moving on, the final stretch. Okay, our last presentation is advancing to ambulatory and day surgery in Pcnl, and we have Jialun to present that.
Very good afternoon, everyone. I'm Jialun from Tan Tock Seng Hospital. I'm very happy to be here. Pcnl patients used to be admitted to the inpatient wards as a routine in terms of same-day admissions for our institution. So on review of our data, we looked at it and we realized that a large proportion of patients actually went home after a one-night stay with no significant complications. Internationally, ambulatory Pcnl is actually also gaining traction, as we heard this morning. With COVID-19, patients actually don't really want to stay in hospital, and we have also a very tight bed situation. And thus, we decided in end 2019 to explore admitting these patients to the ambulatory short stay ward after surgery instead to reduce inpatient bed needs. This ward is situated next to the operating theatre and is distinct from the inpatient wards. They are discharged by the 24 hours or on same-day discharge depending on the progress of the patient. We exclude patients that need either a prolonged period of monitoring or patient that needs a higher level of inpatient care. For an ambulatory ward stay surgery, patients admitted are anticipated by nursing staff to go home on POD1. Patients are monitored overnight post-operatively with discharge on POD1 after review of the patient within 24 hours of the admission. For selected patients, we also carry out day surgery Pcnl. Patients are reviewed post-operatively and decision made for day surgery if the patient remains well, with no signs of infection or overt bleeding. To illustrate, this is my patient that I did 2 weeks ago. It's a patient with 1.9 cm lower poststone, 56-year-old gentleman, ASA2. He was keen for mini Pcnl and was keen for day surgery if possible. So the case finished at about 11 o'clock. We ended well, no intraoperative events that were significant. I saw the patient at about 12:20. He had a stable blood pressure, no fever, and the IDC was actually about pink, so we did a trial catheter. I saw him again about 4:40, 4:20, and then I felt in discussion with him that he was quite keen for home, and we discharged him from there. So in tandem, we practice strategies to decrease morbidity for ambulatory Pcnl. Preoperatively, selection of cases is very important in terms of the patient, the stone characteristics, and infection risks. OT sequencing is important in this case, so we try to put patients a plan for day surgery as the first case of the day. Patients also need to be willing to accept that they may go home on the same day after a Pcnl. We also base on a RCT that we give IV tranexamic acid for patients with gallstone score 3 or 4 in more complex stone surgery to try to decrease bleeding risks. Intraoperatively, we perform mini Pcnl if possible. We also do wideband ultrasound Doppler imaging. So if you see on the image above, this is a real-time ultrasound done by myself, and you look at the vessels that there are, And we don't just do a transperiphery puncture, we go in between the vessels. So we try to decrease traversing of vessels as possible to be accurate in terms of puncture to decrease bleeding risk. We also use selected use of flexible cystoscopy if needed to decrease ARU risk post-operatively. In terms of lithotripsy, the main aim is to make the patient endoscopically stone-free. So I am quite particular that I make sure that I do a flexible nephroscopy, I inspect all calyces on II, and make sure that the patient is stone-free. And we have continued bladder drainage throughout the operation. In terms of exit strategy, the main aim is to decrease tubes in the patient post-operatively. We practice tubeless procedures, meaning say that there's no nephrostomy tube with a DJ stent in 70% of our cases, and totally tubeless, meaning entirely no nephrostomy, no DJ stent in an additional 22% of cases. And this actually helps to reduce the nursing needs to take care of these tubes post-operatively. So only 8% of our patients have nephrostomy tubes post-operatively. Post-operatively, it's important to have early review and early TOC if the patient is planned for day surgery. We also give strict return advice to the patient, and we need to educate the patient very well in terms of what things to expect, and to sense symptoms, mild hematuria. They may not be very serious to need to come back. I also provide my patients with a contact number for my nurse coordinator to contact me if needed in terms of questions, and this helps to decrease readmissions. We also carry out selective phone follow-up by the surgeon on POD1 to make sure the patient is well and answer any queries the patient has. So for day surgery, the areas highlighted in blue are very important because this helps determine whether the patient can go on the same day. And to note that we must always be adaptable, and the patient, if there's any reason we need to either watch overnight or convert to inpatient, we do that over time. So in terms of results-wise, our total PCNL cases in our series of 2020 was 53 cases. Last year, we did 74 PCNLs. For ambulatory short-stay cases, we had 11% of total cases in 2020 and 38%, 28 cases in 2021. For day surgery cases, we had 2% in 2020 and 14%, 10 cases in 2021. So review showed that prior to 2020, the average length of stay for patients admitted to the ward was 3.2 days. This decreased to 1.6 days in 2020 and 1 day in 2021. So overall, we see a shift in terms of cases that the large majority actually go home on the same day or on POD1. We looked at the bed days saved for the hospital, and actually we saved 124 bed days for every 100 patients post-implementation of this short-stay ward and day surgery program. Of special interest was day surgery cases in our series. We had 11 day surgery cases. This is aside from the ambulatory short-stay ward patients that stayed one night. These patients went home on the same day. The median age was 55, mostly ASA2. Stone-wise, most had a guide stone score 1, with an average stone size of 1.68 centimeters, and largest we've done is 2.4 centimeters. In terms of PCNL strategy-wise, all were supine with a single puncture, all were mini with a majority of 16 French sheath, all did not have nephrostomy tubes, with 55% being totally tubeless with no DJ stent as well. There were no complications or 30-day readmissions in our series. To conclude, we have successfully implemented a short-stay program in a short-stay ward setting for our PCNL patients with possible day surgery. Our preliminary small day surgery numbers show it can be possibly as safe as RRS while being day surgery as well in selected patients, and this is backed up by our complication rate data. This maximizes the use of existing resources, conserving precious inpatient beds for more critically ill patients requiring a higher level of care. So 124 bed days were saved for every 100 patients. By also adopting miniaturization and tubeless procedures, this has led to a lower risk of morbidity and a shorter duration of stay. Patient selection and education remains very key, and we need to have a very close partnership with our patients. So we continue to track our data in our PCNL journey. Thank you very much. I'm happy to answer any questions that anyone might have. Thank you.
Do we have any questions from the judges?
You presented the results on the 11 patients. How about those ambulatory? Are they, is there a difference why some were ambulatory short stay and some were day surgery? Was it logistics or bed situation, or it was actually a set of criteria that you did not, you have not presented to us?
I think yes, thank you for the question. I think it's all that you mentioned and above. So I think firstly, patient must be willing. And secondly, in terms of case selection is important. I think we choose cases that have low risk of infection, low risk of bleeding. Intraoperatively, you need to make sure the patient is well, the procedure went well. Logistically, it may be a challenge because you need to put these patients at the first case of the day. So you know, to plan in terms of what your cases are for the day, in terms of OT sequencing. I think that's important. We have moved such at this point in time that most patients are counseled to stay one night, but before the surgery on the day itself, I speak to patients, I kind of like talk to them and see what their notion is. Like what gentleman did, I kind of talked to him, say that would he like to go home the same day? I could tell that he was actually very keen. So for patients like that, then I consider a day surgery, and after the procedure, I'll say that he can go back home. So I think the next step really is to list patients straight for day surgery. We say from the outset, I would say that you're probably a day surgery case, but if any issues, to stay overnight, whereas we are doing the vice versa now.
I'm just wondering, do you look at like stone size, location of stone, and how much operating time? I mean, was there looked into, or is it clear criteria, or I mean?
I think there's no exact number per se, but in my mind, in my series, in terms of cases I do, more than 90 minutes in terms of operative time, endoscopic time is high risk of sepsis, that's number one. A pre-op urine culture is positive, I tend not to. Okay. Otherwise, in terms of intraoperative, if there's any signs of bleeding, any concern that I need to watch a patient, I have a low threshold for keeping overnight, because I think that's more important than trying to send a patient home on the same day.
Yeah, I got a couple of questions.
Sure.
The first one is, what is the modality of stone fragmentation and how to retrieve the fragment in your mini-perk?
So in our mini-perk, currently right now, we use a Karl Storz sheath. So in terms of series 16 French, centrium profile for both the MIP set from Karl Storz, the 18 French was a Cleopatra sheath. That was the point in time we were using Cleopatra. In terms of the modality, is actually a laser lithotripsy. And in my technique, I use mostly fragmenting because I find that it's the most efficient with a mini set. In our series, it's all supine. Our institution does about 90% supine, 10% prone.
So fragments will remove with basket and the graspers?
So actually, no, it's actually done by the Venturi effect that comes out through the sheath itself. If you have slides back, basically the video that I had, if you could get the slides back, please. It shows that the stones actually come out with a Venturi effect. It's called a vacuum cleaner effect, and it really depends on the irrigation that you have and the difference in terms of the size between your scope and the sheath. So the MIP Karl Storz set is very good because they've designed it in the sense that the 12 French scope and the sheath is a good diameter such that this Venturi effect is accentuated. And I find that is actually quite fast in the supine position.
Okay, my second question is, looking at the baseline characteristics of the stones, how will you select patients for mini-perk versus RRS? The stone size seems to be amenable to RRS, and all RRS is almost always day surgery with no puncture, minimal risk of bleeding.
So thank you for the question. So I ask myself that as well when I counsel patients. I think it depends on the patient itself as well as the stone characteristics. So we talk about the size of the stone as well as the Hounsfield units of the stone, whether they're more amenable to IRS. There's a 2019 meta-analysis done by Guido Guisti in European Urology comparing 1 cm and above stone sizes and this comparison between RRS as well as mini Pcnl. So the outcomes from that meta-analysis shows that there's a higher stone-free rate with mini Pcnl compared to RRS with similar complications. So in my hands, in my institution, I feel that it's better for the patient in this sense for stone-free rate, but it really needs to be a discussion with patients. Some patients don't want a percutaneous tract. Our transfusion rate is 1%, and that's 1 out of the 74 cases that we had last year, which is very low. There was 0 angioembolizations last year. So in my hands, I think that is a very important point in terms of high volume that I can tell the patient that these are the rates I have, and let the patients choose. The other important question is quality of life. So there's a Japanese paper talking about, ESWL versus RRS in terms of quality of life, in terms of the overall time frame. And actually, patients that go through ureteroscopy, and I'll draw the analogy to that, actually have a poorer quality of life because these patients may end up having a GA, failed access to stenting, stent symptoms, and you have to wait for the next elective list, like mine is 2-3 months away. It's very hard to slot them in, and they have to deal with the stent over time. In a 1.9 cm stone, you may not clear the stone in one setting, may need a second situation. And that's really the journey that they face, compared to a journey where they come in, it's a percutaneous mini PCL, go home, totally tubeless as a possibility, and they are well. So I think that's kind of where I come from in terms of counseling patients. Personally, 2 cm and below, I do mini PCNLs. 2 cm above, I would err on the side of a 24 French standard sheath.
Okay, thank you very much, Jalun. Okay, we have come to the end of our abstract podium presentations. Before we wrap up, I'd just like to invite Dr. Kenneth Chen, who is our other scientific chair, forward to present the certificates to the participants today. So first we have Dr. Samuel Lee. All right. Next, we have Keong. Okay, your friends over there. Okay, next, we have Ms. Chow Kitman. Hey, Dr. Tan Yu Guang. Okay, and Dr. Kwok Chia Lun. As a final thank you, I would just like to express my deepest appreciation to our 3 judges who have very kindly stayed almost 2 hours judging all these abstract presentations. There will be a prize-giving presentation at the Congress dinner. So those of you who participated today, please make sure that you're there and that you have RSVP. And we'll be handing out prizes at that time. I would just like to just pass our judges a small gift as a token of our appreciation. Okay, and with that, we are done. Thank you so much for today, and we will see you all at the faculty dinner later, for those of you who are coming.